you know, with a tendinitis, you always want to work within a pain-free range. So you actually want to, when you go out, it's all about stability, right? If I'm going into external rotation, I want to make sure that I stabilize my shoulder blade, right? So that I can come out into external rotation. And you see, like, my elbows stay at 90 degrees. So I'm at least, I'm using the correct muscles, right? So I'm almost like going into a W format. A lot of times people do it and they want to go straight out, and then you're not working it as well as you could, right? When you go into internal rotation, then what you want to do is you want to make sure that you're not squeezing too much into your body, and you're going to start out here, and then you're going to come into the middle of your belly. See, if I'm coming into the middle of my belly, so I start out here and I come into the middle of my belly. So a lot of times if you're coming in here, or you're coming out here, or you're going across your body, then again, you might not be in the best position. It's not going to hurt you. It's just maybe not necessarily going to help you as well. Because you're a loosey-goosey person, you need to pay attention to your stability, right? I'm not even going into like core and like legs, or, you know, but it's something that you can try. But definitely one of the biggest things with medial epicondylitis is I do a lot more shoulder, and I get the pain down using the shoulder, and I don't do a lot of wrist extension and flexion. Philip, what do you do?
Also, I think it depends after you evaluate. We want to find out if the instability is caused from the shoulder, or it's just the laxity of the elbow. So we address, if it is from the shoulder, we always treat the proximal, then we come to the distal joint. But it's an interesting case, you know. I think we need to know more about her case.
I always look, of course there's joint laxity because she's a loosey-goosey person, right? So I always look at someone's like hypermobility, and I'm like, yeah, but she doesn't have an injury, so there's definitely a laxity there.
Have she tried the taping, like to stabilize the
yeah, that's what she was saying. She's tried the taping, and the skin was irritated. But a lot of times, one of the things I'll do is I'll approximate and shift. But you can't do that to yourself, you know? So I'll approximate and shift. And once I approximate and shift, the joint, sometimes you'll feel like, oh, that actually feels better when like holding it and shifting it, and then I get them to move and it feels better. But the problem is like Sydney can't do that to herself. You can sort of use your leg, but
one more thing is looking at her chair, you know, the armrest is a little high. I don't know if she's like, when she's resting the arm on the chair, and if she's doing for a long period of time, if that is causing her more discomfort.
Yeah, I'm at the point where I can't do that anymore. So it's
it hurts.
pretty tired. So I don't rest on anything anymore.
Yeah.
But I guess is the hope that as I strengthen those middle and lower foot traps and like strengthen the serratus anteriors for like a long period of time, and then I could keep working.
Yes, I think so. I had a terrible case of tendonitis when I started an outpatient. Oh my God, but it was my lateral epicondylitis, terrible. And I'm a loosey-goosey person, and I'll tell you some of the best things that helped me were the T's, Y's, and I's. And the way I talk about the positioning is in the showcase, and do it without weights. But you need to do it with controlled motion. Right? So a lot of times people are like, oh, I do the Y's, you know, and you actually want to do it first laying in prone, so that the mat or the mattress holds you in place. And then you would do the Y only to the line of your body. You wouldn't go further. You would focus on scapular stability. You're looking to improve for stability, right? You're looking to improve for stability. You're not somebody who needs to do it for motion. So try the internal and external, and I would go real light And a tendonitis protocol is very low and slow. It's the most boring ass protocol ever. But you can start there. Definitely scapular. Do you do T's and I at the level of the body too? So I do T's. Imagine I'm lying down. I do T's. Usually I do T's thumbs out, right? T's thumb out. So if you are, as long as you're just squeezing your shoulder blade, right? You're just coming, the eyes are coming a little bit beyond. When you do T's, you come to the line of your body. Sorry, I'm showing you, right? So here, hand at shoulder level, you do T's, right? Hand at shoulder level, and you working on squeezing. So someone like her, I would recommend doing prone versus with a band here. So the band here, you have to keep your arm in abduction. It's gonna work your upper traps more and your deltoid. But if you're in prone, you're really just going against gravity with those particular muscles. So T's, and then T's with the thumbs upward to the ceiling, right? Thumbs upward to the ceiling. And then Y's, right? Y's are here. And then Y's with the thumbs pointed up towards the ceiling as well. T's, Y's, and I's.
Actually, the Y's are for the lower trapezius.
Yes, they are.
And it stabilizes. It's like very important, especially if you're doing a lot of overhead activities. You need a very good
and they're important for reducing the pain too, like because you are getting even more stability. So Y's are important, but Y's are the hardest ones.
Yeah.
Y's are the hardest ones.
We don't use the lower trapezius that much, and so when we have an issue, that's when they find out that lower trapezius is weak.
Yep. So that's why I do T's, and then I do Y's because they're harder, and then I do I's. So it's like medium, hard, and then easy. So I tend to do it in that order sometimes. But yeah, I'm not a huge if you deep tissue laser. Yeah, so some people love the laser stuff. I'm not necessarily a modalities person, but I think that there's a lot of things that could help. But she's tried a lot of stuff, and I think that something that she could do on her own would be some of the strengthening. Do I do that with the lateral epicondylitis? Yes, I do. A couple of other things too. Okay, there's a Wartenberg syndrome question. Patient was sent with Decker veins, eval and treat. I ruled out that he has absolutely no pain with any resistant testing, negative Finkelstein, but had complete numbness on the dorsal-radial surface of the thumb. He also had a significant indent on his wrist from his watch. I guess I'm wondering about further treatment for him. Bigger wristband. Once we assume the case was his watch, is there really anything else for you to do? You doing manual, doing nerve glides, kinesiotaping his radial nerve on slack. After 2 visits, he said the numbness was 25% better. 3rd visit, he said it wasn't any better. So yeah, I think you still have more to do. Did education decreasing rotation, but not sure if he's taking that very seriously. Yeah, so if he's a manual laborer, it's gonna be really hard for him to like not do stuff. But yes, you want to glide and work through the whole system. So if he's stuck over here, you can do a lot in terms of radial nerve glides. You can also make sure that just because he's stuck here, can you work some more of his forearm to loosen him up? But yeah, if he's only 25% better, there's still more for you to do. A lot of times I will work the skin and fascia in the direction that will feel good for him. Does that help? All right, last question, we gotta go. You had a question on finding multiple patients with a distal radius fracture with a bump developed at the end of the radial wrist. Where's the bump? So a lot of times if they have a radial bump over here, I always check to see if it's as pronounced on the other side. I think a lot of times it just has to do with the scarring. But as long as they have, you know, motion, and they move their skin and scar, over time, all of that will flatten, and the edema will, once it goes, it takes, for edema to fully go away after a surgery, it takes more than 6 months, almost 6 months to a year. So what happens is they'll see the dramatic change at the beginning, and they expect that the change that's dramatic at the beginning will be dramatic continuing on, but it doesn't. It starts to taper down, and then it's really, 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 really slow. 6 months to a year. But I had a woman who, she was gonna change all her jewelry because she wore tons of jewelry on her wrist, and I said, give it a year, your swelling will go down to nothing, your scar will completely flatten, and then only after a year, if it doesn't change, then you change your jewelry. Sure enough, she came a year later. She was someone who visited from Israel every summer at Miami Beach, and she came a year later. I could hear her tinkling with all her jewelry, and she was like, look, I didn't change any of my jewelry, and you were right. After a year, I like it's the same. So really, honestly, those things take so much longer than people want it to take. All right, you guys, great call. Thank you so much. Any other questions, you can message me, email me. All right, good call. Thanks, guys. Hey therapy friends, it's Hoang here. Thanks again for watching my video. And if you like videos like this that can help you just crush it in the hand therapy world as an occupational therapist, then hit the subscribe button and enjoy the video. Thanks again for watching.